Okay, I think we can begin now. So I'd like to start again. Hello and welcome everybody to the Family Heart Foundation's Back to Basics Familial Hypercholesterolemia webinar. My name is Stacy Lane. I'm a board member of the Family Heart Foundation and also someone who is living with familial hypercholesterolemia. That's actually a mouthful, so I think I'm going to say from this point on FH and extremely high Lp(a). The purpose of this webinar is to introduce you all to the language, concepts, treatments for this potentially life-threatening but eminently treatable genetic condition. We're going to give you the ABCs of FH. If you would like to learn more, there are more detailed webinars available on the Family Heart Foundation website. But this is really to get you used to the language that you will be hearing on your journey learning about FH. So we are joined today with my co-host, Dr. Joshua Knowles, a highly respected physician and scientist in the FH universe. Dr. Knowles will give a presentation, and it will be followed by a Q&A. But before we really begin, I have some housekeeping that we need to take care of. This webinar should be used exclusively for educational purposes. If you need medical advice, please contact your healthcare provider. Or if you need help in finding one, the Family Heart Foundation has resources available that you will hear more about later that can help you. Also, we'd love you to use the chat function to introduce yourself and tell us where you're from. It's important to change your settings to everyone so we can all meet you. And if you have any questions, which I'm sure you will during Dr. Knowles' presentation, please use the Q&A function and he will answer them at the end of his presentation. And most importantly, we need to thank our sponsors, Amgen, Esperion, Kaneka, and Family Heart Partners. Without their generous support, we would be unable to present this webinar to you. So without wasting any more time, I'd like to introduce you to Dr. Josh Knowles. Josh is an attending physician in the Stanford Center for Inherited Cardiovascular Disease, where he treats patients with familial hypercholesterolemia. He's had a long-standing interest in the genetic basis of cardiovascular disease and, in particular, the use of modern genetic techniques to improve our ability to diagnose and treat patients at risk for heart disease. He is the Family Heart Foundation's current vice chairman of the board and chief research advisor.
Thank you so much, Stacy. It is great to be with you and to be here. There's no stronger supporter of the Family Heart Foundation and its mission than you. So we appreciate you being here, your years of service. I know the weather is not that great in New York right now, and even braving the conditions is great. It's great to see so many people. I've seen the chat, people from all over the country. And please get your questions ready. We're here to answer your questions. We won't take anywhere near the entire hour. So we'll be happy to answer questions, as Stacy said, but we won't give specific medical advice. Okay, how about we go to the next slide? So really, familial hypercholesterolemia. It's a real mouthful. It's a lot of syllables, but really what it is family high cholesterol. And what is cholesterol? Cholesterol is a fatty wax-like substance. It is a necessary precursor for some of the critical things in our body, like hormones and vitamin D. Most of the cholesterol we produce is made by the liver. After we eat fat, we eat cholesterol. It goes into our gut. The gut packages it into particles that then go to the liver. The liver takes in this cholesterol and fat, and it repackages it into these lipoproteins that circulate on the body. The cells of the body take the tiny amount of cholesterol they need, and they send LDL cholesterol. LDL is the low-density lipoprotein cholesterol, but we really call it LDL. LDL is then sent back to the liver for recycling. And so really we can conceptualize LDL cholesterol as a waste product that needs to be recycled. And really the fact of the matter is, in familial hypercholesterolemia, the bottom line is there's a defect in the body's ability to recycle LDL cholesterol. LDL cholesterol concentrations remain high, and that's toxic to blood vessels. It's really quite common to have elevated cholesterol in the United States, but individuals with FH are a special class. They have severely elevated cholesterol, much, much higher than is typical than average. So why don't we go to the next slide? I'm very excited again that you're here. This will be available to everybody in the future. We're recording this, and that's part of the reason that we're recording this is because there's always new information, and we want to make sure that's available to our community and constituents. What is FH, familial hypercholesterolemia, and how common is it? That's a common question that we get. It is common. It's probably the most common genetic morbid condition in all of medicine. It affects probably 1 in 200 to 1 in 250 individuals in every population that's been studied, and is even more common in certain founder populations. But the key is that individuals with FH have elevated LDL, low density lipoprotein cholesterol, due to genetic mutations that affect the body's ability to clear it. And as a result, as I said, these are toxic levels of LDL cholesterol in the bloodstream, which affect blood vessels over time. You can go to, yeah. So really, again, just think family history plus high cholesterol equals familial hypercholesterolemia. And abbreviating it, FH, is what I do. It's what all of my colleagues do, and it's what patients should feel free to do. We really think about LDL over 190 in adults as signifying a level that should trigger in our mind your physician or your healthcare provider to think about FH. And in children, the number is a little lower, about 160, because normally kids have much lower cholesterol than adults. FH is common. Again, 1 in 250 people in the United States have FH. It doesn't seem like a lot, but that's more common than things like hypertrophic cardiomyopathy or Marfan syndrome or other genetic conditions you might have heard about. And the key is that while 1 in 250 have this condition, less than 30% of those with FH have been diagnosed. And so what we're missing out on is the opportunity to talk to those people and intervene with them with potentially life-saving therapies and diagnostics for their family. So it's common and it's morbid. It's life-threatening if it's untreated, but as Stacy said, it's eminently treatable. So left untreated, 25% of individuals with FH may have experienced a cardiac event like a heart attack or stroke, need for stents, need for bypass surgery by age 40. And it also causes early death. It's a very significant cause of early onset sudden cardiac death. 1 in 10 heart attacks under the age of 50 is caused by familial hypercholesterolemia. And it's especially more common in those with familial hypercholesterolemia plus other risk factors like high lipoprotein A or smoking or high blood pressure. We think about FH, although it's a bit nuanced, we really can conceptualize it as a disease that's passed in families. And classically, it's been thought of as an autosomal dominant condition. That means each person has 2 copies of each gene. And in FH, all it takes is 1 bad copy of the gene, which you inherit from 1 parent, to have a high likelihood of having this condition. So if you have FH, you have a 50%, each of your children has a 50% chance of passing it on. And so one of the things that we always say is that we never find an individual with FH, we only find families with FH. Is there more than one type of FH? And whenever you get that kind of question, you know the answer is going to be yes, there is more than one type. The much more common type is heterozygous FH or HeFH. That means you've inherited a single copy of a bad gene from either your mother or your father. And That leads to LDL cholesterol levels, again, in adults, usually greater than 190. To give you a sense for what that means, the average LDL cholesterol for an American adult is about 130, and maybe 125. So LDL over 190 is a high suspicion for FH. Coronary heart disease can happen in the 30s to 60-year-old range, and it's very responsive to drug therapy. It is common. The more rare type, homozygous FH or HoFH, means you've inherited a bad gene from both mom and a bad gene from dad. That's a much more severe scenario. LDL cholesterols are usually over 400. Coronary heart disease can happen in childhood. In fact, there are many case reports of children needing bypass surgery in their teenage years if you have HoFH. And there are some new medications that have just been approved in the last 10 years that are extremely important for HoFH patients. But this is much more rare. Only about 1 in 300,000 individuals have homozygous FH. How do we diagnose FH? And this is a common question we get also. But again, the key things to remember is a family history of high cholesterol, very high cholesterol, or early heart attacks or strokes, and high cholesterol itself, seen in family members or especially personally, should lead one to suspect FH. There are some telltale physical exam findings that we see. These are not always seen. In fact, they're probably found in less than 20% of people these days. However, if we do find them, they're very pathognomonic. They really mean we have a very high suspicion for it. If cholesterol cannot be cleared by the liver from the bloodstream, it deposits in places it shouldn't, like around the eyes. These are called xanthelasmas. If you circle that around the eyes, you can see the xanthelasmas. It can deposit in the around the eyes, and actually there's a theory that Leonardo da Vinci identified xanthelasmas in the Mona Lisa, and you can Google that and see those pictures. But the cholesterol can also deposit in the tendons of the hands and of the Achilles tendons, and that is also commonly found. In homozygous FH, the physical manifestations are also much more severe. The cholesterol is often deposited in very large xanthomas that are present around the elbows, the knees, the hands. These are often seen in childhood and may be the first thing that leads a pediatrician to consider homozygous FH. These are usually present in these cases, but often misunderstood. Sometimes people have never seen this in their practice. There is, thanks to the Family Heart Foundation and other organizations that supported us, ICD-10 code. This is an international classification of disease code. This is what healthcare providers use when they want to code you in the medical record, and how we justify the tests that we do. We use these codes. But and if you go to the next slide, you can see that there's also the ability to do genetic testing in cases of familial hypercholesterolemia where it was suspected. And the Family Heart Foundation was instrumental in bringing these world experts together to come out with this genetic testing statement, which essentially says we can diagnose familial hypercholesterolemia genetically. There are some advantages to offering genetic testing, and it should be offered as a routine standard of care to all individuals with suspected FH. This does not mean, however, that you are obligated to get genetic testing or that it's absolutely necessary for a diagnosis, but it should be offered like genetic testing is offered in other similarly morbid genetic conditions. Genetic testing for FH is very reliable. It is standardized. It can be done at multiple laboratories, but it is always the choice of the individual as to whether they want to get that testing done. There's some evidence that it helps diagnose and family screen. It can sometimes lead to more aggressive therapy or individuals to consider more aggressive therapy, but it is important to note that we treat the LDL cholesterol levels. We don't necessarily treat the genetic test, but it really is it is an important part of our ability to diagnose treat, screen individuals with FH. And there are lots of resources on the Family Heart Foundation website to answer a lot of questions around genetic testing, because we know it's not always done. What should I do when I find out that I have FH? And this is really quite critical. The number one thing, well, one of the number one things to do is, again, we know that it doesn't stop with the individual. There's potentially affected family members at either earlier or older ages. So there are some great studies that have come out from the Netherlands and Europe that shows if you find one individual with FH and you screen the rest of their extended family, you often find many other undiagnosed individuals, and you're able to intervene with them. So family screening, which we call cascade screening, you cascade down from the first person, is quite important. So cascade screening is critical. You should have children tested for familial hypercholesterolemia. The guidelines really say that anybody with a family history, any children with a family history of FH or very early onset heart disease should be had their cholesterol checked by ages 2. That doesn't have to be a fasting lipid panel. It's hard to get children that age to fast, but any lipid panel testing can be done. Genetic testing can also be done at early ages. And it's also important to realize that the American Academy of Pediatrics recommends that all children should be screened for cholesterol levels, because sometimes the parents don't know that they have this condition, and sometimes we find families by starting with the children. Another important risk factor, as I said, is lipoprotein A. Lipoprotein A is an LDL-like cholesterol molecule that floats around in the bloodstream, and the co-occurrence of FH and high LPA is particularly dangerous and should be screened for in all FH patients. And that is a routine laboratory test, although it's not on all standard lipid panels. And so sometimes you have to specially request that from your provider. That's all really important stuff, but what about treatment to lower the cholesterol levels and lower the risk for heart disease in individuals? And that's what the next few slides are going to focus on. So diet, exercise, and controlling risk factors is really important. We always think that these things are the foundation of good health. Diet and lifestyle management are important. There's a lot of controversy about dietary recommendations, but one thing that's clear is that if you have a very strong genetic predisposition to high cholesterol, a low saturated fat diet is recommended, and there's good evidence that it's helpful. High soluble fiber. We refer all of the FH patients, or offer all the FH patients an opportunity to see a dietitian so they can know really what foods to avoid and what foods to target. It's also important to control all the other risk factors that contribute to heart disease. Exercise regularly. We don't do a great job of that in the US. Maintain a healthy weight. Don't smoke. Check your blood pressure and your blood sugar. But really, the key about FH is that if we identify it early enough and we treat it early enough, we can really change the trajectory of the disease. And this is a great slide that was published a few years ago. And I think on the y-axis, what we see is cumulative LDL cholesterol burden. And the way to think about that is kind of lifelong LDL cholesterol burden. It is akin to sort of pack years of smoking for cigarette smokers, but this is sort of pack years of cholesterol, how many years you've been exposed to high cholesterol levels. On the x-axis is the age in years, and the lines, the graphed lines, are the age at which we would expect individuals to start having heart disease. And I said, homozygous FH patients often have such high cholesterol from such an early age that they start to experience heart disease in their teenage years. An untreated heterozygous FH patient, shown in the red line, can often start having heart disease if they're left untreated in their 30s or 40s. But if cholesterol medications are started and a healthy lifestyle is started at an early age, you can bend that curve and you can delay the onset of heart disease essentially to that of people that are unaffected. The orange line is those that do not have FH. So you can make any FH patient look like an unaffected individual with very early and very aggressive therapy. You can actually take the plaque that's starting to develop in the arteries And with very aggressive treatment, we've shown that you can even start to reduce the plaque that's already started to form. The goals of therapy is really to reduce the LDL cholesterol. If you reduce the LDL cholesterol, it has extreme benefits in reducing the risk of heart disease. In adults, a minimally acceptable standard, if you've never had a heart attack or stroke, is to get the LDL to less than 100. If you've already had a heart attack or stroke, a minimally acceptable standard is to get the LDL cholesterol less than 70. But many of us would even be more aggressive about that. And actually, the Europeans are now starting to recommend getting the LDL to less than 55 in in high-risk patients. So all patients with FH are considered high risk. There are very few scenarios in adults in which we would not recommend cholesterol-lowering therapy. It's critical to control the cholesterol. And statins are often the first line of therapy. They're really the first line of therapy worldwide because they're so potent and effective. They're very safe, and especially in FH patients, they're safe. But combination therapy is often required. We often cannot get away with just one cholesterol medication if we want to lower the LDL cholesterol to healthy levels. Many times FH patients start with LDL cholesterol levels in the 3 or sometimes even the high 300s. And so sometimes more than one medication is necessary. Treatments, we're kind of in a golden age of lipid-lowering therapy, golden age of cholesterol-lowering therapy. For a long time, what you can see on this graph is in the 70s, we had this, the first cholesterol-lowering medication was kind of a bile acid sequestrant. It was almost like a resin, like a sand that people would take. It had some side effects. And then statins became introduced in the mid-80s. And then we really didn't have any other therapies for close to 20 years until ezetimibe came on. But then in the last 10 years, partly because of many advances in the pharmaceutical discovery era, some of it brought on by genetics, we now have many, many more non-statin therapies that are available for us. We have PCSK9 inhibitors, which were approved 8 years ago now. We have another cholesterol-lowering medication called bempedoic acid, which was especially important in patients with statin intolerance. We have another PCSK9 inhibitor called inclisiran that can lower cholesterol and only needs to be injected twice a year. And then we have two pretty specific medications for very severely affected homozygous patients, lamidipide and evinacumab. Those are homozygous FH specific medications. But really, the mainstay of therapy is statins. The second line therapy would be ezetimibe or Zetia. These are both generic pills that are taken and are extremely effective. And then the third line therapy would be these PCSK9 inhibitors, either alirocumab, evolocumab, or inclisiran. So we have a lot of tools in our toolbox that we can use to help patients. Individuals with FH, as I said, and ASCVD, that's atherosclerotic cardiovascular disease, that means a prior heart attack or stroke, often require or usually require 2 or more lipid-lowering therapies to reach healthy levels. And that is critical. We know from our Family Heart Foundation registry called Cascade, where we've been following about 5,000 or 6,000 FH patients over time, that we can really do a good job as a community getting the cholesterol lowered, but that requires often 2 or 3 medications in some cases. How much cholesterol lowering do we expect with these various treatments? And this goes to why sometimes 2 or more medications are needed. Diet, and especially low saturated fat diet, exercise, healthy lifestyle, lowers LDL 10 or 15%. So nothing to sneeze at, but not enough. Statins can often lower LDL cholesterol levels by 50% or more. Ezetimibe or Zetia is a little less potent, but it's very well tolerated. Similar effect sizes are seen for things like bile acid sequestrants. Those are the oldest cholesterol-lowering medications. Bempedoic acid, the newest one on the block. And then PCSK9 inhibitors are really about as potent as statins. and are really have been game changers for severely affected patients. In terms of homozygous FH patients, these are the homozygous FH specific medications. And again, these individuals often start with LDL cholesterol levels 400 or 500. And so they often need, more than 100% reduction in their LDL to achieve healthy levels. And they really require these very specific medications. And this just reiterates, statins are the first line of treatment. We always get a lot of questions about statins, but the most important thing about statins, one of the most questions we get all the time asked is, what are the side effects? And for FH patients, the most important side effect is less heart attacks and strokes. And I don't say that tongue-in-cheek, that's really true. They all have small amounts of side effects, but those are really the most important side effects, is people will live longer, healthier lives with FH. The most commonly used statins, and the ones in our guidelines, are atorvastatin, which used to be called Lipitor, and rosuvastatin, which is also called Crestor. Those are the most potent statins that are very well tolerated. There are a large number of other statins that are sometimes used in specific circumstances, and those are shown here if you happen to be on them. It's not that they're bad medications, they're great medications, but the most commonly used ones are atorvastatin and rosuvastatin. One of the questions we get asked is, what about children? Do children always need medications? No, they don't always need medications. There are some specific guidelines about when to consider statins in children, and it often has to do with how high the cholesterol is and what is the family history. But statins are very effective in children, very safe. And I love this. This is a paper that was published a few years ago from the Dutch experience, where they have studied hundreds of children with familial hypercholesterolemia over the years. And what they found is that the children with FH that were started in childhood, they had already started to show manifestations of disease. They had already had blood vessels that were starting to show damage. But when they were started on statins, that damage started to reverse itself. And after 20 years, the children that were able to get treatment were already starting to outlive their parents, who did not have the opportunity for treatment because there was no treatments for their parents. So the children with FH, you can see in the red line on the left, they're already having less heart attacks and strokes at an early age, even into middle age, and compared to their parents, and they're actually living longer than their parents with FH. So intervening early is really important, both in young adults and in children. And that's shown in a more granular data here. None of the FH children who began statins in childhood but died by age 40. And in the parents, on the other hand, 7% of the parents had died before age 40. So that's over 100% reduction in the chances of cardiac death. So really important data that was published by the Dutch, and we're very indebted to all the work that's been done in the Netherlands over the years. How much does lipid-lowering therapy decrease cardiac risk? For every 40 milligram per deciliter decrease in LDL cholesterol, cardiac risk falls by 20% per year. So this is a very, very large effect size. You will start to see benefits from cholesterol lowering almost immediately. The cholesterol will drop, and even after a year of therapy, your risk of heart attack is substantially reduced. And every year you take the medications, that risk reduces further. That includes, that has been shown for statins and other medications that are also very effective in lowering LDL cholesterol. There are, again, new therapies in development. This is a very hopeful time for FH patients. And they have not all been approved, but there are lots of ongoing clinical trials for medicines that we think will be very effective. Some of these include oral PCSK9 inhibitors. So these are PCSK9 inhibitors that don't require injection. There's other drugs called CETP inhibitors, and there's even now trials worldwide of gene therapy to actually edit the genes to reduce cholesterol and hopefully decrease outcomes. There's a lot of information about this on the Family Heart Foundation website. We're here for you. We want to help you. The Family Heart Foundation was founded by individuals affected by FH and with high LPA. There's a care navigation center. So if you reach out to this center, they have real people that will help you navigate your way through your journey. And now we're happy to take some questions.
Thanks, Josh. That was incredibly informative, and I know a lot of information, but we do have a bunch of questions here. And again, I want to thank all of you for listening to the webinar. And if you do have any more questions, just keep sending them and we'll answer them. Let me see. So, and I'm not going to identify people, but is it possible to have a negative genetic test but still be diagnosed clinically for FH?
Yeah, that's actually not just possible, but very common scenario. And there's a couple possibilities for why that might be the case. One is we just don't understand all of the genetics of FH. So it's possible that in the future we'll identify new genes, but it's also possible, and we've learned now, that people can have very, very high polygenic risk. That is, instead of having a single gene with a very large effect size, you happen to get 2 FH level cholesterols through having hundreds and hundreds of changes and hundreds of genes. And it turns out that if you have those kind of changes, you're still at very high risk and should be managed very aggressively.
Okay. That's actually a very important thing, because I think it's important for people to realize that you don't need a genetic test, and even if it comes back negative, you still need to be treated. Okay, here, this is a question. How do we get our clinicians to listen, to test more, to understand family history of cholesterol is not a diagnosis? After losing my 20-year-old son, I'm driven to raise awareness on this.
Well, that's I'm also seeing in the chat, there's some really poignant stories about loss at early ages. And that's really the mission of the Family Heart Foundation, is to try to raise awareness amongst healthcare providers, amongst the public. And we're glad you're here. And I'm sure that we'll be able to put you to work to do that.
Absolutely.
I would just say one more thing. I mean, there's no one answer to that question. That's a question. How do we change the whole mindset? And it's about education. It's about advocacy. It's about changing guidelines. It's about going to Capitol Hill and changing how things are reimbursed and paid for. And it's about going to medical schools and teaching about the importance of this. And so it's really takes a multi-pronged approach to change usual patterns. And that's one of the things that the Family Heart Foundation has done, is try to take a multi-pronged approach through working with individuals affected, with family members, with governmental agencies, with funding groups, with insurance companies, with payers. And that's why we're starting to shift the dynamic a little bit, but it does take time.
We've made progress, but there's a long ways to go on that, I'm afraid. Are there any of these treatments for FH safe during pregnancy or breastfeeding?
Yeah, there are actually one of the oldest cholesterol lowering medications, the bile acid binding resins, are safe during pregnancy. We use them routinely. They're not especially potent, but they are used. They are safe. They don't get inside the body itself. They work exclusively in the gut, and they've been given the clearance by the FDA. And it also turns out that we're rethinking the potential toxicity of other cholesterol lowering medications, which had a theoretical risk, but that has not really been borne out. And so there are very specific cases at which time, for instance, black box warnings have been removed from statins during pregnancy and breastfeeding. And so this is ongoing work, and I think guidelines will continue to change. But you should definitely talk to your healthcare provider about the specific case.
just to add a personal note here, I have 3 children and I have FH, and I took a bile acid sequestrant through all 3 pregnancies, and they're now grown-ups. So there are treatments available. Does FH involve cholesterol only? My daughter's triglycerides are what tend to be elevated the most. She was diagnosed with FH at age 17.
Yeah, this is a important question, and historically, we used to think that high triglycerides would never be seen, or very, very seldom be seen, in individuals with familial hypercholesterolemia. But over time, and FH, the genes that control FH are really involved in LDL cholesterol metabolism. But we now know, due to the vicissitudes of modern life, that sometimes individuals can either have diet or lifestyle changes that are associated with high triglycerides, or individuals can have FH level cholesterol, LDL cholesterol levels, and a polygenic predisposition to high triglycerides. And so that can also be seen. So there are several ways. High triglycerides does not exclude the diagnosis of FH, but it is not as commonly seen.
Does the diagnosis of FH include patients with high LPA only, or with normal LDL? How about high LPA together with LDL? Is that fairly high, but less than 190?
Yeah, so lipoprotein A there's a couple chat questions. Lipoprotein A is an LDL-like cholesterol particle, lipoprotein, with an extra protein tagged on the outside of it. It is a separate and distinct condition from familial hypercholesterolemia, from FH. So they really need to be thought of as kind of separate conditions. But that being said, the risk, you can have high risk from LPA, just like you can have high risk from LDL, and having them in combination means especially high risk. So you can have, it wouldn't be termed familial hypercholesterolemia for somebody having pure high LPA, but that doesn't mean you don't have high risk, and other things should be addressed.
Just as a plug for the Family Heart Foundation, we have webinars on Lp(a) as well, if you are interested, and a lot of information available on our website. Okay, this is something I have not heard of. Can you discuss the value of the cholesterol balance test in order to determine if you're a hypersynthesizer or hyperabsorber? This nuance could help fine-tune the medications, but we can't buy these online in New Jersey. It's frustrating.
Yeah, I don't know a lot about that testing. What I would, and so I don't want to get into the pluses and minuses of it. Certainly, high cholesterol, high LDL cholesterol, can be contributed to by hyperproduction, but really all of the treatments for LDL cholesterol, a lot of their effects is by increasing the recycling capacity of the liver for LDL cholesterol. So I don't know about the utility for that test. I don't use it in my practice. So I think I'll just stop there.
If cholesterol is used to make vitamin D, and someone is taking Zetia for FH, would their vitamin D levels be adversely affected?
Yeah, there's been a lot of studies about this, and it turns out that the amount of cholesterol that you need to make vitamin D is really tiny. And even the most potent cholesterol medications do not impact that ability. There are many reasons to have low vitamin D levels, but the cholesterol medications are not thought to be a major cause of low vitamin D.
How does a patient manage, this is a more specific question, a CPT2 deficiency if they have high FH or high LPA and FH?
I don't know what that is, actually. I don't know what that is. I do see some chat questions about what does a high LPA level mean and what would be considered high. And a high LPA level there's two tests for LPA. One is in nanograms, one is in milligrams per deciliter, and one is in nanomoles per liter. And there are different scales for both of them. In milligrams per deciliter, we have a slide on this. The Family Heart Foundation has a slide on this on our website, but some people say over 30 or over 50 milligrams per deciliter and over 75 nanomoles per liter. But we often see people with LPA levels 200 or 300 nanomoles per liter, or 150 or above milligrams per deciliter. So those are considered high. There's a question about colchicine. Colchicine acts in a different way by theoretically by decreasing inflammation. And there's been some modestly positive trials and some modestly negative trials. And so the jury is a little bit out on colchicine as to whether it should be routine part of care. It's currently not routine part of care. It doesn't lower cholesterol levels itself. There's a good question about what do we do for high LPA, and when high LPA is identified, what do we do about it? Because I think the question inherent in that question is the acknowledgement that we don't have great medications that lower LPA right now. They're in phase 3 clinical trials. We think that LPA specific lowering medications will be available in the next 3 or 4 years, but in the meantime, we really, really work hard at the other risk factors. So we get the LDL lower, even lower than we would without high LPA. We consider the use of PCSK9 inhibitors, which modestly lower LPA a little bit earlier. And patients should definitely consider enrolling in those clinical trials. There is LPA under very rare circumstances is even treated with apheresis, which is a dialysis-like program that removes LPA. But that's not very routine in the United States.
So here's another LPA question. My LPA was elevated, so my sister's was tested. Or she has 2 sisters. One was normal and the other was elevated, but insurance refused to pay for it because they said it was experimental. What do you do in that case?
Yeah, this is a real This is something that the Family Heart Foundation is fighting hard for. LPA measurements are definitely not experimental. They are recommended as standard workup for people with a family history, especially of heart disease. And so we are fighting that battle constantly, and are seeing some progress in that. It's very, very frustrating, but the correct documentation by the ordering provider is really key right now. And but it's something where it's some markets and some insurance companies are more forward thinking than others, and so it's something that we're working on.
Okay, this is an interesting question. Normally, when I see my doctor or endocrinologist, they do not tell me my LDL levels in milligrams per deciliter. For example, if my LDL levels are 7.8, how do I find out this level in milligrams per deciliter? And why does that happen?
You must be outside the United States. Is that caller from somewhere else?
I can't see, but I would imagine.
Yeah. So in much of the world, they use millimoles rather than milligrams per deciliter. And there are conversion factors. And for LDL, you multiply that 7.8 by about 40. I think it's like there's like 38 point something, but 39 point something, but there's a conversion factor that will allow you to convert it to milligrams per deciliter. But if you're outside the US, there are both European or international guidelines about what should be your target in millimoles per liter. And generally it's less than 2, something like that.
Is there a standard way to calculate it, or is it you just multiply it and that?
Yeah, that's the standard way. You multiply the millimoles per liter by I think it's well, we can look it up right now, but yeah.
While we wait for that, I'll ask you something else.
Yeah, keep going.
Okay. Is inclisiran a PCSK9 inhibitor or a small interfering RNA? I was under the impression that inclisiran had a different MOA. I don't know what MOA stands for.
Mechanism of action. Yeah. Yes, so inclisiran and the other PCSK9 inhibitors, is that the question? What's the difference in the mechanism of
Like,
action?
how's inclisiran different from other PCSK9
Yeah,
inhibitors?
so the initial PCSK9 inhibitors are antibodies. They are antibodies that are injected every 2 weeks. The antibodies bind to the PCSK9 in the bloodstream, and then they help remove the PCSK9 from being able to work. Inclisiran is a different type of drug. It actually works in the liver. It's injected, it goes to the liver and prevents the body from making PCSK9. But they both are very effective. They have about the same effectiveness level. They are a different mechanism of action, and they one drug has to be injected every 2 weeks, and the other one every 6 months or so.
Okay, I think we have time for one more question. Oh gosh, and I just lost it. I'm sorry. Give me 1 second. I'm sorry. There are multiple research studies showing that saturated fat intake has opposite effects on LDL versus LPA. For example, more saturated fat lowers LPA while raising LDL. What dietary recommendations would you provide for a person with extremely high Lp(a) and essentially a normal LDL?
Yeah, that's a very challenging question. That's a very, very challenging, very nuanced question. And that's almost getting the realm of specific medical advice. But in general, we would probably fall back on recommending heart healthy diets that have the greatest evidence of utility. Things like the Mediterranean diet and the DASH diet, where we have pretty good evidence that they're effective no matter what your cholesterol levels are. That there would be no national or international recommendations for somebody with high, for instance, LPA to eat a very high saturated fat diet or something like that, just because it might have slight effects on lowering LPA. We know that it's probably going to take medications that lower LPA levels by 80% or more to be very effective. So the dietary modifications you do for LPA probably are going to be not especially effective.
Okay, I think that is about all we have time for. Let me see. So first of all, I want to thank Josh for being, for this wonderful presentation. I think it was incredibly helpful. And again, the fundamentals of familial hypercholesterolemia are not easy. So please know that this webinar is going to be on the Family Heart Foundation's website. So it's there for your reference. It's there to help. Just a couple of other little announcements. We have other classes going on, something called the Cholesterol Master Class, which you can join us. It's 4 sessions in November, and you can register on familyheart.org. And this is actually quite important. FH Awareness Day worldwide is September 24th. And to give the Family Heart Foundation a plug, we started this about 11 years ago, and it has become a worldwide phenomenon. And on this day, you raise awareness of FH to save generations of families from heart disease. We have media packages available. We have information available. You can learn more on familyheart.org, FH-awareness-day. It's really a very exciting day, and I hope you consider doing something with us for that. And then we have our first time in, I think it's now 4 years, our Family Heart Foundation's Global Summit. This is a gathering of leaders in medicine, in science, in public policy, in industry, all gathered together to sort of solve the problems with FH and other inherited cholesterol disorders or lipid disorders. It's almost sold out. It's in Washington, D.C., the beginning of October, but you're invited to register at familyheart.org/summit. We'd love to have you. And really, finally, we're here for you. We have something called a care navigation center, which many of people who have FH have taken advantage of, where we have a genetic counselor there available to talk to you. We also have sort of information on negotiating insurance issues, and also to help find a physician, because I know many of you don't live in areas where there are lipid specialists available. And we can be of great help in this regard. So if you have any issues, please go on familyheart.org/care. And this obviously is very important. In order to be able to do what we do for you and do for people with familial hypercholesterolemia, it is essential that we have funds to operate. So if this webinar was helpful to you or to members of your family, or you want to learn more, we would love it if you would donate to the Family Heart Foundation. Any amount is appreciated. We would love to have you involved. We have a large number of patients who have sort of joined our Advocates for Awareness programs. We have lots of different things, but to do all these different programs, we need financial support. So if you can, we would love a donation to our organization. And lastly, I want to thank you. Thank you so much for joining us. I hope this was an informative use of your time. And as it says, we are here for you. And thank you, Dr. Knowles, for your time.
Thank you, Stacy, and thank you to the organizers at the Family Heart Foundation, and for those of you that took time out of your day to be here. Thank you.
That's great. Thank you.